morning, everyone, and welcome to Breakfast at FOM. Very happy to have all of you here today as part of our initiative for our Odyssey Organ Donation Week. We are very happy that University of Malaya has allowed us this platform on Breakfast and FOM today to speak to you all about organ donation. And today we have two wonderful speakers. We have Dr. Maisara, Associate Professor Dr. Maisara, and she's a nephrologist in University of Malaya and also a senior lecturer. She's quite heavily involved in the recipient part of organ donation. She's also one of our Odyssey trainees. She's been very active even in the organ donation scene as well. And she's going to speak a little about her experience in organ donation as a healthcare worker. The other speaker, we have Dr. Yap Mei Hoon. She's actually an intensivist from PPUM. And for those who are not sure, basically intensivists are the doctors who look after ICU. She is also instrumental in organ donation in as you know, and she's also an Odyssey trainee as well. So for all those who are joining us for this webinar this morning, you could actually ask this question in the Q&A chat section of the Zoom, and we will try to answer all of your questions later. So without further ado, I would like to present the first speaker, Associate Professor Dr. Maisara, to share her slides and to give a talk. Enjoy.
Thank you, Dr. Koong. Okay, anyway, I'm still Odyssey trainee, Dr. Koong, which is my head is Dr. Koong. Okay, so yeah, by the way, my name is Maisarah. I'm one of the Odyssey trainee from University of Malaya. Thank you for having me today to talk on my experience with organ donation in Malaysia. Of course, we have we have organ and tissue donations. In terms of organ, we have liver, kidney, lung, and heart transplantations. While for the tissue, we do have cornea, bone, heart valve, as well as skin transplantation. But since I'm a nephrologist, my main focus today is talk to you about the kidney transplantation in Malaysia, how we are doing so far. This is outline of my lecture. So basically just a brief introductions, what do we mean by renal replacement therapy, prevalence of end stage in Malaysia and worldwide comparison, where are we at present, kidney transplantation and dialysis, why it's matter, kidney transplant team, what is available so far in our country, and what's the journey of potential recipient of donor in our country. So as you can see here from the world map, we are in blue. Malaysia is one of the developing country with 32.5 million populations in 2021. We have observed the increment in the new case of end-stage kidney disease, and the number is projected to be continuously rising. So as you can see, we are in blue there. Among the Asia-Pacific region, we are among the highest country that have high prevalence and incidence of end-stage kidney disease. After the diagnosis of end-stage or advanced kidney disease, the patient, prior to that, the patient will undergo some counseling in terms of renal replacement therapy. What do I mean by renal replacement therapy? Once the kidney has failed, the patient needs to do either hemodialysis, peritoneal dialysis, kidney transplantations, or in fact, in selected cohort, palliative care therapy. So as you can see from here, based on USRDS data, the incident treated end-stage kidney disease in 2018, Malaysia has been listed as number 11 top globally with reported incidence of more than 250 per million population. As you can see, we are among the top country that has higher incidence of end-stage kidney disease. And you can see from this graph that our incidence of kidney disease is continuously rising as well. We are among the top countries in the chart. Looking back what we have in terms of our registry, this is based on stock and flow of new end-stage kidney disease in 26 Malaysian dialysis and transplant registry. We noticed that in 2018, we have about 8,431 patients, which is newly diagnosed in that year with end-stage kidney disease, while majority of them undergo hemodialysis as a mode of therapy. Is about 7,200 patients doing hemodialysis. And a small proportion of them doing peritoneal dialysis, about 1,231, while very little number down here that had transplantation is about only 90 patients. So you can see it's kind of a very huge gap in between. This number was increased exponentially with only 4,606 patients 10 years ago, which is in 2008. As from this graph down here, you can see the proportion of new end-stage kidney patients by modality, and green is transplantation, red is peritoneal dialysis, and blue is hemodialysis. Only small number of them underwent transplantations. Okay, this make a total number of patients remain on dialysis up to 2018 of 44,136. And you can see here again, majority of them had underwent hemodialysis. You can see out there is many centers, new centers of hemodialysis in order to serve their needs as a support because of they had a kidney failure. Only small number of peritoneal dialysis, about 4,000, and up to 2018, we only have 1,801 had kidney transplantations. So you can see very little of our proportion of our populations had underwent kidney transplantations. Yep, where are we from the how are we doing so far? We know that the reason why we had increase of incidence in stage kidney disease, one of the reason because majority of our populations had diabetes as the main reason why they had end stage. In fact, in the world, we are number 2 in terms of percentage of incident cases treated end stage attributed to the diabetes after Singapore. So we are from these Asia Pacific countries, Singapore, Malaysia, that very rich perhaps in food, lifestyle, things like that. That's the reason why we are among the top in the country. But sadly to say that in terms of the modality treatment, where are we stand globally? You can see we are little down there, and very blue is transplantations. Very small proportions of our country populations had underwent transplantations. We are far below Singapore, and of course far below the other country in Asia Pacific as well. And as I highlighted before, majority of our populations had underwent hemodialysis, and they are still on hemodialysis up to the present. That's why this happened, because of we don't have enough donor, we don't have we need to have more donors for them, because many of them are from younger populations, but they don't have a donor for them to undergo kidney transplantations. Yeah, again, this is the prevalence. We're still down there. We are Thailand kind of doing better than us, Singapore on the higher sides than us as well. So why kidney transplant? So what I like this graph because this is a survival benefit of kidney transplantation, but bear in mind in this study group is not straightforward transplantations without any complication. This is a cohort that had underwent very intensive immunosuppressive therapy or plasma exchange prior to the transplantations. Even though this individual is high immunological risk for transplantation, they had underwent desensitization therapy, which is involved a lot of immunosuppressive drugs. End of the day, eventually their outcome is still much better if these populations remain on dialysis. So you can see here the survival benefit is a lot more if you're doing transplantations, even though you need to undergo a lot of procedures, but eventually the outcome is better in terms of overall survival. Yeah, here is basically a list of advantage why kidney transplant is better, because number one, longer lifespan and better physical health. I've highlighted the survival benefit earlier on. Better quality of life. You do not need to go to dialysis center 3 times a week, 4 hours for each time. They're able to go to work, better social life. In terms of the fluid, they have more freedom, no fluid restrictions. Traveling, that's not an issue. And of course, long-term analysis has documented that it's actually cheaper if you underwent transplantation as compared to remain on dialysis. The disadvantage, of course, because this is a kidney transplantation, you need to be on lifelong immunosuppressions, you need to undergo a major surgery, and if you are waiting for a deceased donations in Malaysia, longer waiting time for deceased donation is the disadvantage of this. So if you want to compare transplant and hemodialysis, for transplant, you need to have a kidney donor that fit to undergo transplantations. Is either this in the context of living donations, but for hemodialysis, you need to have permanent vascular access. We still have many admissions related to catheter-related bloodstream infection as a complications of a hemodialysis catheter. So this is obviously take a lot of time, cost, hospital admission, and poor survival benefit for the patients. In regards to the transplantations, patient need to take long-term immunosuppressions, but don't forget, our hemodialysis patient does take plenty of medication in order to manage their anemia, their renal bone disease, and their underlying comorbidities like diabetes, hypertension, dyslipidemia. In terms of diet, like I mentioned before, they are more free in terms of diet. They just need to maintain a healthy lifestyle to manage underlying comorbidities. However, in hemodialysis patients, you need to refer to dietitian for low phosphate diet, for low potassium diet, for low salt diet, water restrictions, no durians, no nice fruits, things like that. Okay, and complications of CKD mostly corrected after the transplantations, but in hemodialysis, we are struggling in terms of managing their hemoglobin, their renal anemia, their renal bone disease, their phosphate, their calcium. Of course, transplant has complications, and the graft with, eventually will fail and not last forever. But median survival about 15 to 20 years is good enough for one patient to enjoy the benefit with good quality of life. But in hemodialysis, you need to think back. The patient end up with exhausted vascular access and eventually leading to palliative care because there is no other options available if this patient is not suitable for peritoneal dialysis. Usually in transplant, the reason why we monitor them frequently because they will some of them can end up with infection related, especially first few months after the transplantations. But in hemodialysis, you always heard about the sudden deaths during dialysis. So all this attributed to the cardiovascular event. So in UMMC or University Malaya Medical Center, we have a dedicated team that is involved transplant physicians, we are very grateful to have a team of UMMC physicians and to have a team of UMMC team that always support her. They are very dedicated, make the transplant possible in our center. Nurses, dietitian, medical social welfare, to be involved with the patient management. And of course, there are few others out there of which that we need to submit some document, seek for some approval, or in fact, with the National Transplant Resource Center, when we do have a deceased donation via the hospital donor coordinator teams. Um, So what's the process? What is available in Malaysia now? Of course, we do have living and deceased donations, but majority of our populations now what we have is living donations. Living can be either living related, which is first and second degree family members. If they are third degree family members or they are in-laws or they are not related, we need to go through unrelated transplant approval committee or UTAC to seek for approval before we can pursue transplantations. For emotionally related is spouse, okay, a registered marriage spouse. If they are not registered, is a girlfriend or boyfriend, we still need to go the unrelated transplant approval committee to get the approval. This committee will interview a potential donor and recipient whether or not they are suitable, whether or not there are any other gain behind it, benefit behind it they are seeking about. So they will assess the patients. In terms of living related, straightforward transplantation, blood group compatible, of course, by having a O blood group, you can donate to anyone that you want to donate to. But of course, the certain blood group like A, B, you need to donate with similar blood group. That's what we call it ABO compatible. While HLA compatible, which means that this patient did not have any donor-specific antibody. This antibody developed through the sensitizations event, of which from prior blood transfusion. That's the reason why in patient with advanced kidney problem, potential kidney transplant recipient, we try to avoid blood transfusions. We manage them with erythropoietin and iron, because of blood transfusion will lead to development of antibody in the patient's body, and this antibody perhaps later on will kind of recognize the new kidney of which not belong to the patients, and ultimately rejections. So that's straightforward transplantation. The second one, we do ABO incompatible, which means that this patient do not have similar blood group, but through the desensitizations protocol, of which I will highlight later, these patients able to do transplantations. The third one is they do have donor-specific antibody through the previous event. And these patients, we need to further re-stratify them immunologically and decide on whatever best for these patients' immunosuppression therapy, of which to make them to be able to undergo transplantations. And finally, we still have a group of not suitable kind of for transplantation, because they do have very high level of antibody, very high of anti-A and anti-B titer. They still remain under the transplant waiting list and waiting for disease transplantations. The reason why I highlight DBD, because this is a donation after the brain death. This is the only thing that we have done so far. Of course, we do have one case of DCD, but years back ago, but it's not sustainable. Of course, I will talk about it later in terms of DCD. So there are 6 hospitals in Malaysia performing transplant surgery from 3 different settings. Ministry of Health, you can see Hospital Kuala Lumpur here, Hospital Selayang here, Ministry of Education, UMMC and UITM, as well as the private center. Okay. Now, I would like to briefly highlight the journey of potential donor and recipients. This is our transplant counseling. So, those patients that have a potential kidney donor are welcome to contact us, of which we will set appointment for transplant counseling and briefing by our transplant coordinator nurse. Following that, of course, we will decide. Some patients come to us with many donors, but as a physician, we will advise this patient who is the suitable donor, or if perhaps difficult for us to make decisions at that particular time, what we do is we would like to send the HLA typing or tissue typing. Of course, the good donor and recipient, if we can match both class 1 and class 2. And we do send at the first beginning stage, we need to send a cross matching. The reason why we need to send this is to evaluate their status, or whether or not they do have the antibodies towards the potential donor. Other basic blood tests, which is renal function test, liver function test, full blood count, the ABO blood group, which is very important. If this is ABO incompatible, we need to send either anti-A or anti-B titer to evaluate how high is this patient risk or how low is this patient risk in regards to the ABO incompatible. Tumor marker, of course, in very selective group, the list of virology screening, because we know that post-transplantations, after they had intense immunosuppressions, these viruses become reactivate and cause problem. The second step, they need to underwent, after the first step, the nephrologist will review the patients, whether or not this donor is suitable to the recipients, and give some advice in terms of what we are dealing with, whether or not we need to do transplant. test, things like that. Following that, this patient will undergo a cardiac workup, pulmonary, OGDS, mammogram for female, pap smear, dental clearance, and assessment of pelvic vessel. You can see from here it's very intense workup that we need to do, because remember, this is an elective operations, as if like these patients need to run a marathon. They need to be fit for the operations, and all the other risk factors need to be managed prior to the transplantations. And about similar tests that recipient need to undergo, except that we need to assess properly in terms of the recipient kidney function. We do the standard gold standard, which is chromium, EDTA, or the MSA test, in order to know which kidney is the best function, what is the overall functions. Of course, end of the day, what we want is safe, is a better quality of life and safe procedure for the donor as well, and reduce the risk of future end-stage kidney disease for donor. Thus, we really need to evaluate them so that they don't have any kidney problem, and they do have enough kidney function to donate the kidney. After that, we will set an appointment for the patients to see our nephrologist for the transplant cooking. Basically, what we are doing here is to make sure this patient is fit, whether or not we need to refer to other subspecialties. So I believe from the audience here that some of you might get a referral from me. Like for Koong, I always refer when this patient has elevated CEA for some colonoscopy, for some hepatobiliary problem, and for cardiology, when their stress test is not adequate, they couldn't run, things like that, and perhaps this patient needs to undergo angiogram. So those kind of things we need to further optimize these patients. So eventually, after all the workup has completed, we need to repeat the cross-match, because along the way we don't know this patient had developed some antibody towards the donor, and we need to send a very sensitive test, what we call it Luminex single antigen beads. This is to identify very specific antibody, whether or not this patient has antibody towards the potential donor. And once all done, we will give vaccinations. Of course, the COVID vaccination is not available yet, but what we do give so far is basically the influenza vaccine, as well as the pneumococcal vaccine. Apart from that, we will refer to psychiatric for assessment, surgical team that always support her for surgical assessment in terms of their pelvic vessel, the patient's anatomy, and the anesthetic assessment as well. I do mention about COVID swab, because in this COVID era, we do need to do 2 repeat swab for all the potential donor and recipient to make sure they don't have any problem. Okay, what we do in the final review, usually the transplant nephrologist, we see them, this is basically to re-stratify them to choose the best induction and maintenance immunosuppressive therapy for this group of patients in order to prevent acute rejections later on. Of course, some of the patients, they are still kind of very challenging. They do have very high level of antibody, or they do have very high level of A or B titer in terms of ABO blood group incompatibility. Thus, we couldn't proceed with transplantation, and this patient end up in the waiting list. What we want to do for these patients, this patient has a donor, but it's just that the antibody levels is just too high. So yeah, the strategies I will briefly kind of inform later on. So in terms of in highly sensitized patient, we ourselves have published a case series in our hospital of doing this patient with antibodies, and this was started in 2016. We call it HLA incompatible kidney transplantation, because they do have a lot of antibody towards the kidney donor. So our protocol consisted of rituximab and plasma exchange for these patients, and after that we give an induction of thymoglobulin, which is very intense immunosuppression lymphocyte depleting agent for all these patients, followed by the maintenance immunosuppressive therapy. You can see from here, this patient need to be admitted away before the transplantation for this procedure in order to bring down the antibody level. How about the outcome? You can see here their creatinine, of course, this is just a 1-year outcome. Their creatinine level are comparable with those low-risk patients with straightforward transplantations. And I highlighted again the survival benefits from the previous chart. In terms of ABOI, we in this center as well has performed few ABO in compatible kidney transplantation, and this is a collaborative study and experience among other transplantation in Malaysia. As you can see that the donor and recipient has different blood group. Majority of AB donor want to donate to all kind of recipients, so they need to undergo this very intense immunosuppression. That reason why we are very grateful to have a blood bank in our PPUM, of which we always request for AB plasma from the blood bank, and they always accommodate us. So end of the day, we need to balance between donor well-being and benefit. Of course, we need to select the good donor with minimal long-term risk of kidney failure. At the same time, we need to respect the donor candidate autonomous decision to seek the benefit and accept the risk of kidney donations. Okay, what's next? So as I mentioned here, that you can always see from whatever happened in our country at current present, that our kidney transplantation is still very low. We only have 1,000 plus kidney transplanted patient, while our end stage patient is about 44,000. How we want to do this? That's the reason why the Odyssey come into the picture, which is a very good program indeed. And the awareness in terms of the disease coordination. If you are one of the Facebook follower, you will see Dr. Iqbal, Dr. Koong and their teams always hashtag FIKE transplant. So because we have a lack of organ pledge, we need to increase this. Sometimes we do have see some refusal, difficulty in getting consent from the next of kin. So we need to motivate all the publics out there, and we need to increase the referral numbers from the respective unit. So talking about the DCD, I think some of the country, especially in United States, they have increased their statistic in terms of kidney donations, because they take into account donation after circulatory death. However, in our country, I believe we need to have more consensus on it and SOP in terms of this development. Okay, I did mention just now those patients with very high antibody level and very high AB titer, of which they're not eligible for the living related transplantation. They keep waiting under the waiting list. So hopefully we can this can be doable in the future, which is kidney PET exchange. This basically we need to get more approval in terms of implemented this. Arthristics, I think, is a long way to go, and is need more work in terms of this. So how are we doing at present? As you can see here, we UMMC, okay, I would like to highlight here, we started our living related program in 1991. So this year is basically our 30 years living related kidney transplantation celebrations. Okay, and we started our disease in 1997. So you can see from the left hand side, HKL has been started earlier, as our first living started in 1975 and our disease 1976. But our disease number, even though there has been started the kidney transplant program earlier on, but the disease number is still single digits in a country similar like us. So this is subsequent years. You still, as you can see here in UMMC, we have zero donor from 2008 up until 2012. Okay, only in 2013 we do have some donor, and surprisingly in 2020 the number increased by 2 from previously. It is double actually. We are very happy and we are proud to say this. Even though it's still single digit, but I think hopefully one day the numbers is in increasing trend. Similar like HKL, hopefully this number can be sustained. And you can see our living program since 2017, the number has increased more than 2020, because I think we stopped our operations about 2 to 3 months COVID at that time. Thus the number decreased to 19 patients, but we do have a lot more potential donor and recipient that need to go for transplantations. Similar like HKL, good that their number also increasing. So that's represent we are doing something for the country. Hopefully this number is sustainable and continues like rising. So I do mention about the highly sensitized patient just now. So what the best option for them? Hopefully kidney PET exchange become doable in Malaysia. This has been practiced elsewhere in the developed country. When you are not meshed with your recipient, basically the team will discuss who who is your best donor for the kidney to get matched and exchange for you to have a better kidney in the future. And hopefully with these implementations, we can reduce the rate of rejections and the graft can survive longer. Okay, with that, thank you. Hopefully you guys will be together with us celebrate 30 years UMMC Living Kidney Transplantations. We start on the 31st January 1991 and this year, 31st January 2020 is our 30-year celebration. We do have a few kind of program outline that will be announced later. Hopefully everyone can join us for this celebration. Thank you. Back to you, Koong.
Thank you, Dr. Maisarah. Prof. Maisarah, I always say it wrongly.
No, it's okay, Koong.
Now, for those who just joined us, thank you again for joining us. I think we have a great amount of attendees today, about 160 of them. Basically, I am Dr. Koong. My name is Koong Jun Kit. I'm from the Department of Surgery. And I'm also one of the Odyssey trainers and Odyssey program manager in Malaysia. For those who are not sure, Odyssey is actually organ donation initiative in Southeast Asia, whereby we try to teach organ donation education to healthcare workers. But coming up next is Dr. Yap Mei Hoon, and she's an intensivist from ICU PPUM. Today she will be sharing her experience as an intensivist role and also a healthcare worker's role in organ donation in a hospital. Dr. Yap, please go ahead.
Okay, very good morning, everybody, and happy 30th anniversary, Maisara. Today, my talk will be on healthcare workers' role in organ donation in the hospital. Okay, sorry. Okay, I'd like to start off by saying that being part of and being a witness to a successful organ donation is a very humbling experience. And when you see such a selfless act, especially in the case of disease organ donation, giving the gift of life to a total stranger, it really renews your faith in humanity. And I hope by sharing my experience in disease donation today, I'll be able to inspire you to take an interest and support organ donation in PPUM. So what I'll be doing today is walking through the different stages of the organ donation process. So this would include organ detection, donor detection, evaluation, and then the diagnosis of brain death, donor maintenance, family approach, and finally the organ recovery and allocation. So the first step in this journey is actually donor detection. And the objective is actually an early referral of potential organ donors by the treating physicians wherever they are. So sometimes the referral can be even earlier than that. So a potential organ donor is someone who has irreversible from severe brain damage, and you suspect that the patient to be brain dead. A possible organ donor is a patient who has a very bad head injury and may potentially progress to brain death. So sometimes we get referrals very early, for example, from our ED colleagues, letting us know of patients who had because of the severity and the futility. There's no plan for surgical intervention. So even though these patients they may still have cough gag reflex, they're not suspected to be brain dead at that point, but they are expected to progress to brain death. So the referral can be as early as that. And we would actually follow up these patients, and it's easier when it comes, if they do progress to brain death, it's easier to manage them if we get them early. So some statistics, last year we had a total of 15 referrals, and the common causes of brain death would be traumatic brain injuries, cardiovascular accidents, so hemorrhagic strokes. And so the referrals we get are from the neurosurgical team, the neuromedical team. So as intensivists and as ICU doctors, we do rounds in the periphery as well, and we do pick up potential organ donors. One referral by the top team and one family initiated referral. So these 15 referrals are translated into 5 successful organ donors. And actually last year we were one of the top hospitals in terms of numbers of successful donors. So that's something to be very proud of, but I think we can do better. Okay. So before I move on to donor evaluation, some of the challenges that we face, I think, in donor what do you call that, detection would be the low rate of referrals. So 15 is really not a very high number, and if we don't pick up potential organ donors, we will not have donors. So I think as healthcare workers, we can help by keeping an eye open for potential cases. And it would help if we had a top team full-time combing through the whole hospital, looking for potential donors. Okay, so they're actively looking for donors, and that has actually been shown to increase the number of potential donors rather than waiting for referrals to come in. So the next step is donor evaluation, and the main objective of this is actually to avoid transmission of malignancy and infection to the recipient, and also we hope to aim for the best outcome of the transplanted organs. This involves a careful history and examination. We do look at biochemical parameters, and at this point, early donor evaluation would involve basic imaging such as chest x-rays, and we would prime the family for brain death testing. So for example, if we have identified a potential organ donor in the neurosurgical ward, so if this patient has had a severe traumatic brain injury, and now pupils are unreactive and there's no cough gag, and we suspect this patient is brain dead, what we usually do is we speak to the family together with the primary team, and we first of all assess their understanding of the condition, and it helps that the primary team is there to explain it to them if they don't. So we show them the scans, and we ask them if they understand that the nature of the injury is severe and irreversible. And then we introduce the concept of brain death. So what we usually do is contrast it to cardiac death by, cardiac arrest. So we usually tell them, you know, if your heart stops and you die, that's death, which is a fairly easier concept to understand. But there's also the concept of brain death. So the brainstem controls all your vital, your breathing, and once the brainstem is dead, you lose this vital function and you are also dead. So we introduce this concept, and then we tell the patient that we suspect their loved one may be brain dead, and then we will be proceeding to run a series of tests to confirm this. So at this point, it's easier and more convenient if we bring the patient into ICU to optimize the patient for the brain death testing. So we do need to explain this to the patient if the patient is in another critical area other than ICU, so that they will not be shocked if the patient is then transferred to ICU. So we tell them that we are suspecting that the patient has progressed to brain death, and that we'll be bringing him or her into ICU to optimize for brain death testing. Usually at this point we stop, and if, because we do have to give some time for the family to digest that information. If they do ask what happens after that, so we tell the family that brain death is death, and once that is confirmed, we will off organ support, which means taking the patient off the ventilator. Okay, so why bother doing brain death testing? And this includes establishing if the patient is dead or alive, obviously, and eradicating doubt among the staff and family. So sometimes family can be conflicted. You're telling the family that the patient is brain dead, but they still see the patient's chest rising with the with breathing when the ventilator ventilates the patient. And when they hold the patient still feels warm. So they may not understand that the patient is dead. So there may be doubts among the family. And importantly, it allows futile or inappropriate treatment to stop. Okay. We need to fulfill some prerequisites. So you really need to know the cause of the brain damage and to be sure. And this also helps to establish irreversibility of the pathology. You need to exclude conditions which may simulate brain death. So if the BP is very low and there's no perfusion to the brain, you can't do the brainstem test. Severe metabolic disturbances, severe hypothermia. So we usually aim for a temperature of 35. And you want to make sure that there are no residual effects of pharmacological agents, such as CNS depressants, so sedation, neuromuscular blockers. So in terms of challenges at this point, it's easier to be done for the test to be done in ICU. Hypothermia is a very common, common problem that we face, which delays brainstem testing. So the patient really needs to be warmed up, and in ICU we do this by putting on a bear hugger or heated humidifier, which is connected to the ventilator to bring up the temperature and allow brain depth testing, and it's difficult to be done on the wards. And these are the reflexes that we do test when we do our brain death test. So the pupillary reflexes, the corneal reflexes, response to pain. At this here, that the challenges here would be sometimes if the patient has a very high cervical spine injury, you can't do. I mean, you might not be able to move the neck. You might not be able. If the patient has a very bad head injury and the eyes are very swollen, you may not be able to assess the pupils. And sometimes when you are assessing for pain, you see movements which may confuse you, which may be confused with purposeful movements. So all of these are challenges that we face when we do the brain death tests. Yeah, and sometimes the patient's hemodynamics don't allow us to do the test. So, if the patients are on very high inotropic support or very high ventilator settings, because the brain death test ends with an apnea test, which is where we, there are a few ways of doing it. The traditional way would be to pre-oxygenate and then at some point disconnect the ventilator and wait for the PCO2 to rise to 60 and observe for no respiration at that point. Or we could hypoventilate until PCO2 of 60 and then observe for any breathing efforts. But patients on very high oxygen requirements may not be suitable for apnea testing. So these are some of the pitfalls. Sometimes families don't accept the results of the brain death test. These are some of this is another problem that we sometimes face. So in special circumstances, we do invite family members, one family member, to observe the second brainstem test. We feel that in these special cases, when the family is unable to accept what we tell them, when they see the brain death test done for the second time, it helps with their understanding and acceptance, and we are able to move on. Of course, this is not suitable in all cases. Yeah. And sometimes the family requests for withdrawal before the brainstem test is done. so the first is when they can't accept, and the second problem is when they have so accepted and they don't see the need for the test to be done. We explain to them, like what I mentioned earlier, the benefits of the test. And at this point, even though we usually do not bring up the subject of organ donation before the brainstem test is done, but in special circumstances, we do explain that it is one of the reasons and the prerequisites to proceed with the discussion about organ donation, and sometimes that helps as well. And another problem is sometimes that we face is that a patient who we bring into ICU anticipating that the patient will progress to brain death, and we bring the patient in to do the brainstem test, but the patient then does not become brain dead. So usually in these kind of cases, we wait, and after a reasonable period of time, if it's very clear that the patient is unlikely to progress to brain death, then we discuss with the family the next step and then the direction of care, which could be withdrawal based on the severity and the futility of the situation, or for example, tracheostomy and weaning if the family decides otherwise. So when there's any doubt about the results of the neurological testing to determine death, meaning there are some components of the brainstem testing which could not be done or were inconclusive, then arises the need to proceed with ancillary tests. And examples of these tests include 4-vessel angiography, which would show no circulation in the circle of Willis, radioisotope scans, which would show no uptake, no intracranial uptake, and EEG, which would show 30 minutes of no electrical activity. Okay. So the next step in the whole process would be donor maintenance. So now you have a patient who is brain dead, confirmed brain dead, and at that point you need to maintain you need to perform somatic maintenance, and the whole point of this is to treat complications associated with brain death, and to do a more thorough assessment of organ function. And at this point, you're also ruling out absolute contraindications for organ donation. Donor maintenance is quite similar to the care of any other critically ill patient in ICU. The objectives would be to maintain tissue perfusion, to maintain organ functions. As for any other critically ill patient in ICU, there are hemodynamic targets to be met. Specific complications associated with brain death, we see diabetes insipidus quite often, and this can lead to hypotension from polyuria. So that's something which is quite common in patients who are brain dead. The initial stage part of brain death will result in a sympathetic storm. So initially you might see very high blood pressures, tachycardia, but this is soon followed by a state of vasoplegia, myocardial depression, and you may need to support the hemodynamics with fluids, with inotropes. Very much like a critically ill patient who is hypotensive. Okay. So once the brain death test has been done, we then speak to the family. So usually before the test is done, we tell the family that we are going to do it. Okay, and this prepares them mentally. And once the first test is done, we then assess their acceptance. And we don't talk about organ donation until they have accepted death. So if we talk about it and we discuss it anytime before that, it's really not going to sink in. So we only ask them and approach them for organ donation once they've accepted that that their loved one has died, and is brain dead. This is, I feel, one of the most difficult parts of this whole process. It's such a delicate, subject to talk about. But the more that you talk, the more that family discussions that you take part in, it does become more natural. So I think it helps to put it in a very matter-of-fact way, that something that we talk to all families about once they become brain dead. We ask them what kind of, we ask them about their loved ones, and we can ask whether they what kind of a person was he or she, somebody who liked to help, who liked to contribute to society, and now being in this situation, although it's so devastating that they have lost their loved one, but their loved one now is in a position, a very special position, to be able to give the gift of life to so many other people, and we ask for them to consider it, and we ask and we answer any questions that they may have. It's quite difficult here sometimes because patients, families whom you think will not agree to donation, sometimes they are the ones who in the end consent, and some patients who you think maybe somebody in the family is a doctor, and they seem to be asking a lot of questions and be very interested, they may in the end not agree. So it's sometimes quite heartbreaking at this point. But once the family has agreed, we then ask for their consent. So there is a consent form to be signed, and in this consent form, they choose which are the organs that they are agreeing to donate. And if we explain to them that further evaluation is needed, we will try to evaluate the organ functions non-invasively at first through blood tests or through imaging scans, but really in the end it's the assessment intraoperatively. So we do tell them that occasionally the organs are not suitable to be donated, and in the consent there is a portion where they ask, they tell us what they want us to do with the organs in the event of the organs being not suitable to be donated. So they can donate it for studies, to the hospital, or they can request for the organs to be disposed by the hospital. Okay, so we now have a patient whose family has agreed to donate their organs. What happens next? We maintain the donor. That's donor maintenance, and next becomes procurement, and this usually happens at some ungodly hour of 3-4 a.m. and it's quite a complex process involving multiple internal and external teams. So we have teams from Hospital Selayang, from IJN coming in. There's quite a bit of preparation which needs to be done in OT, and finally body reconstruction. Okay, so in OT, the anesthetist will usually give a dose of muscle relaxants and put on the induction agents, because sometimes there can be sympathetic responses like tachycardia and fluctuations in blood pressure, which may be disturbing to the team. So the patients are paralyzed in the theater and on anesthetic agents. And during the procurement, there's the initial inspection and dissection. So at this point, we involve the pathologist as well. Often frozen sections are sent off the liver to assess the degree of steatosis and to assess for suitability. And then the cannulation of the vessels, cross-clamping and perfusion with infusions of to preserve the organs. The organs are then removed. There's benching done, and finally packed and labeled. Okay, so this is the picture: inspection and dissection. And after the organs are removed, they are prepped in the process of benching. Okay, so as you can see, the pitfalls it's really quite a large team in the operation theatre. It can get quite crowded, chaotic. It needs a lot of coordination, which is why the transplant coordinator is in the OT the whole time coordinating. You know, the external teams may not be comfortable with our OT or vice versa. Our staff may not be familiar with the external teams coming in, so it helps that the transplant coordinator is there. There may be surgical technical difficulties in terms of surgery, which may prolong ischemic time. Okay, so these are the pitfalls. The final journey is once the patient has been the body has been reconstructed, is to accompany the donor to the mortuary. So the transplant coordinator also accompanies the patient, the donor, all the way to the mortuary, assist the family in the paperwork and settling of the bills, and finally we thank the family. And this is a post-mortem meeting that we have at the end of every donation. So we sit together, the whole team, the transplant coordinators, and the doctors who are involved in the donation, and we talk about the difficulties we faced and identify areas for improvement, so that the next donation is done in a smoother manner. And we hope by doing this each and every time, we will be able to come to a point where everything runs smoothly. Okay, actually that's my last slide.
Thank you, Dr. Yap. It's a fantastic and very thorough talk. You can stop sharing your screen. Okay, great. I think we have a lot of questions here, so I will try my best to answer all of them. And basically, let's go on to the first one. I think we have a few questions for Dr. Maisara, and a few questions for Dr. Yap as well, and a couple of questions for both of you. So the first question is, I think there's a question on donor exchange. Is donor exchange currently being done in Malaysia, Dr. Maisara? And the other question, what are your thoughts about that?
So basically, donor exchange, we have kind of try to develop our own SOP and try to implement it, but it's still at the level of discussions, because if you think of donor exchange, it's involved unrelated donor. So logically, it needs to go through UTAC, but by going through UTAC, it's caused delay in certain things sometimes, because if you have a lot more kidney exchange. So what we need to do is we need to present the SOP, the guidelines, how we're going to do it. Basically, we are at the level of trying to discuss with the ministry in terms of the kidney exchange. Hopefully, one day we should be able to do it. Yep, we are on the way there.
That's great. You know, it's always very good to look at this initiative. There's a comment here and a suggestion that maybe when you have the awareness event, we should be inviting all the pioneers of the event. I think this came from Prof. Sarah. The other question that there is for you is that with regards to immunosuppression, I believe all of them will undergo lifelong immunosuppression. Is that correct?
Yes, they are. But depending on their risk, the level of immunosuppression is totally depending on their risk. If they are low immunological risk, the immunosuppression can be reduced and they on minimum dose of immunosuppression. But if they are high risk, they need to be on higher dose of immunosuppression. So it's totally depending on their immunological risk. But they need to be on it lifelong as for now. Yep.
Right. There's another question, maybe both of you can answer, but maybe Maisara, this was directed to you. What do you think is restricting the deceased donation for kidneys in Malaysia? And how good do you think we are monitoring our living donors after that?
In terms of the disease one, I think the problem, like I mentioned before, yes, we need more organ pledge, and eventually after that, it's not all the pledger can be an organ donor. So it's totally depends on what cause of death, what restrict us from, to be a donor. Because we need to bear in mind, of course, we need to assess the cause of death, whether or not the kidney is a good function prior hands or not, whether it is extended or marginal donor. But marginal donor is still good to be donated, especially for those that still waiting and rather elderly. In terms of monitoring, I think we are doing great. But of course, as you guys aware that everywhere in the world, we are dealing with a problem of chronic allograft nephropathy. What we call it rejections, but it's not very bad rejections. It occurs slowly and eventually the kidney will fail. I think that's the problem worldwide. That's the reason why in terms of induction and maintenance immunosuppression therapy, the strategy need to be kind of improvise things like that. But we are doing great in terms of long-term graft survival generally as compared to the world. In terms of monitoring post-transplantation, I think we are doing good, but it's just that how to make it better. And this similar problem, what's the world having it as well.
Yeah, thanks, Maisara. Okay, maybe a question for Dr. Yap now. There's a question that if the provider of the organ, for example, the transplant coordinator, should be different than the person who actually performed the brain death test, would that be more appropriate? What are your thoughts about that?
Okay. So usually the transplant coordinator does not it's not directly involved in the brainstem test. So for example, in our center, I can say that our nurses are the transplant coordinators because like our nurse Aisha, she will organize everything. Once a potential donor has been identified, she'll follow up the case, send the bloods, assist us in the brain death testing, but she's not the one who's the test. In a place where, for example, the treating intensivist is the only person available to perform the test, I don't see much of a conflict in that sense because we are also not involved directly in the transplantation. Our job is more of the determination of brain death by performing the test and donor maintenance. So I don't see a conflict of interest there.
I think what Dr. Yap says is very true. Ideally, the people who detect the donor and as well the person who performs the brain death test should be different. But we are faced in a situation in Malaysia previously. A lot of our the person who actually looks for who identify these brain death donors are actually intensive care doctors and also anesthetists. And this occurs in all of the hospitals in the country now. To increase the number of donors, I suppose sometimes we have to do both jobs. We cannot. So we will probably have difficulty transporting people from a central hospital all the way to a district hospital in order to pronounce brain death tests. Which actually brings me to the next question. There's a question here by Chin. This says that it's asking is that when we've already identified that the person is a potential organ donor, this is what I understood from the question. Is there a need to transfer to a certain hospital for the transplantation after the patient is before or after confirmed brain death?
There is no need to transfer the patient. So the brain death test can be done in that hospital. And usually if there's a need and there are no suitable teams in that hospital to perform the procurement teams will go to that hospital. and so there's really no need to transfer the patient, as far as I know.
So yeah, maybe I can just mention a little bit about that. Currently, we have the organ procurement team, and they're usually from Selayang. They're from the HPB team. They're my colleagues from Selayang, and they procure the liver as well as the kidneys. And the IJN chaps will go ahead and procure the heart or the heart valve and lung if needed. We have a few procurement team who can also take the cornea, but at the moment they're taking the whole eye. And yes, this team work together, and the NTRC manage the logistics for these teams to go and procure this organs. So it's a big undertaking actually from these teams. Maybe I could ask a question for both of you on what do you think about this. Prof. YK, thanks for joining us, Prof. YK. Always good to have you. Is asking about opt-out system and opt-out system policy in Malaysia. Maybe Dr. Maisarah, you'd like to start this?
Yeah, opt-out policy in Malaysia. Of course, this involves a policy making, and we need to understand how effective it is. We do see some countries that do opt out in terms of the donations, but their rate of transplantation is quite rather static and not really much different. So whether or not it's benefit or not, it is something that need to be discussed further. Of course, it's a good move. It's just that it's involved further discussion, legislations, and policy making.
Dr. Yap, any thoughts about opt-out?
Yeah, I think at this point we still very much take the families' consent and views into I mean, yeah, we still take consent and ask them lah. So if they refuse, we respect that. And like Maisara said, I think this change of policy will need to happen over time, and needs to be analyzed further.
Perhaps I can add on to that. Actually, there have been many studies done about opt-out and also opt-in system. Now, what opt-out is actually, well, to those who are not sure, opt-in basically, you have to choose to be an organ donor in order for you to be registered. And that is generally what we practice here in Malaysia. And opt-out organ donation, basically, you are considered an organ donor when you're suspected to be brain deaf, unless you choose to register otherwise. So the countries which practice opt-out, the famous one which we know will be countries like China and as well as Singapore. Now, familiar to us will be Singapore, and Singapore practice what we call a soft opt-out. Okay, so which means, and Spain as well, to be honest. So even they have an opt-out system, it doesn't mean automatically that a person is confirmed brain deaf that they are actually organ donors. And family consent is still needed in soft opt-out in order for them to proceed with organ donation. And I've spoken to my Singapore colleagues who does this as well. And they said that, well, it's true enough that, you know, it increases the healthcare workers' awareness that this can be done. But they will still need to have a good family approach. They will need to speak to the family with regards to having those organs donated. So it doesn't change the pathway much. And there are actually studies that sometimes opt-out could also be counterproductive in terms of organ donation, especially with social media, and also if the public education is not strong enough, if we're not there yet, people might actually have a wrong thoughts about misunderstanding about opt-out system. And what happened is that they may actually intentionally register and say they do not want to be organ donors because of those misunderstandings. So I feel that there's a long way of public education before we can institute the system. That's my personal feeling. Having said that, the country is moving towards a direction, and what is intimated to me by the NTRC is that they have discuss in the highest level in the government, including the religious bodies, to make this into an opt-out system, which could work, but we will need quite a lot of public education along the way. Again, the question, maybe this one we can ask Prof. Maisara. What is the payment like, and what is the cost? What's actually the cost of organ donation in in
So this is in
Malaysia
the
or
context
in
of living related?
maybe you can just inform us of the living first, and maybe Dr.
Yeah,
Yap can inform of the
yeah.
deceased. Yeah.
Sure. In regards to the living related, it depends where you plan to do the transplant. Of course, Ministry of Health, most of the cost will be covered by the Ministry of Health. And I did speak to one of them previously. The patient may end up to pay maybe about 500 ringgit kind of registrations, all the admin fees, things like that. But of course, being in the university hospital, certain costs the patients need to pay, and the imaging, everything, yes, patients need to pay, but of course for the donor, there will be kind of some reimbursement letter, but for the recipient, they end up paying for the images as well as cardiac workup. But those under government servant, all that can be done like other procedure as well. In our setting at the moment, we do assess them immunologically and send the immunology test abroad to our neighborhood country. This is another limitation that perhaps in the future we can build up our own immunological lab. So by sending over the test abroad, it takes a cost about 10,000 overall, including the pre-screening and kind of later on if you want to repeat the test. The images perhaps another 10,000, so that's about 20,000 already, and another 10,000 for the immunosuppressions. But hospital did subsidize their maintenance immunosuppression subsequently, as long as they do the transplant locally. If you are aware that some patients undergo transplant overseas abroad, we didn't say no to go overseas, because we do know that we are limited in terms of organ in the country. But of course, that's something that's against the Istanbul declarations. After they are coming back, we are still supporting them in terms of give them treatment, things like that. But the disadvantage is that they need to pay for full price for the immunosuppressions later on. So that's roughly that's the rough cost, about 30 to 40K for the living related kidney transplantations. But for the government servants, like other images procedure, that can be paid by the government. That's no problem. Yeah. In terms of the disease, technically for the disease, the patients still need to pay. But for the disease, at the moment, because they do have the regular blood test, but of course we do need to repeat at the point of transplantation if they are not supported by government servants, things like that. If the transplant being done in the university, they do need to pay for the echo and the CT pelvis, which is the price for the CT scan and the echocardiogram, about few hundred ringgits. But the immunological test will be free, because it's considered being under the National Transplant Registry course, of which we send to IMR because we need the result as soon as possible. For the roughly cost about the disease, maybe around 2,000, and they need to pay for the inductions, depend what we use. The induction, the one that is quite costly, it can go up to 15,000 for the induction immunosuppressions. But some of the price hospital try to kind of, we have the subsidized program, but of course we need to select the patient, things like that. But if the transplant being done under the Ministry of Health, of course, like I've told earlier, it's hardly any cost if the transplant being done under the Ministry of Health. Yeah.
Thanks, Maisara. Maybe I could just add on to that. Well, the cost of let's talk about cost of disease transplantation. Actually, in terms of disease transplantation, it differs in Ministry of Health and as well Ministry of Education, EPPUM. Here I'm talking about it. In Ministry of Health, the maximum they can charge is actually 500 ringgit for any bill. Okay, but when I calculated the actual costs, here I'm talking about for living liver donation, the cost with 3 months of immunosuppressant actually comes out to about, cost alone, which comes out to about 100,000 ringgit. Okay, so this is a big undertaking. So every time Ministry of Health does this, even though their charge comes out to only 500 ringgit, that's how much the taxpayers' money comes out to. All right. Having said that, when you take the balance of the healthcare cost, it's actually worth it. The other thing is the cost of the donor. I think there's a question about cost for the donor. Who pays for that? So the payment for the donor actually comes from the recipient in living donors in the university. It is charged inside. It's built into it. And as for the Ministry of Health, if you're a organ donor, a living organ donor, then all your bills are actually covered by the government as well. Okay, there's quite a few questions here. I may not be able to answer everything. Maybe we just touch something on brain death. Prof. Gan have been asked a question actually about time of death. Is it at the confirmation of brain death testing? And which one? Maybe Dr. Yap would like to answer that. Then has it caused any confusion and problems with the authorities?
Yeah, so in Malaysia, the time of death would be the second brain death test, but this differs in different countries. As far as I know, that hasn't caused any confusion in medical legal cases such as motor vehicle accidents. And we usually go by the time of the ABG being done. That's the time we take. The second, when the CO2 is 60 and there's no spontaneous respiration. So we have an ABG done at that point, and that's usually the time on that is usually taken as the time of death.
Has there been any problems with the authority? Any problems with the police or the magistrate when it confirms the time of death? Actually,
no. I think the time of death is not, but sometimes the transplant coordinator has to run around a bit if it's a medical legal case, and to get permission and clearance from the magistrate for the test. I mean, for the organ donation to be done. There's paperwork. There's quite a bit of paperwork.
Brain injuries are motor vehicle accidents which are police cases. I have an answer here by Dr. Diana actually, and they themselves have not had any confusion, any problems with the police or magistrates. Okay. Well, we've come quite far in our talk, and I think we're running out of time. And thank you so much for joining us and all of the questions. I'd like to, for all those who have asked more questions and we have not answered it, we will personally email it to you, your answers. The speakers will email to you the answers, and we would like to thank everyone. Thank you, Professor Maisara, for your talk. And thank you, Dr. Yap,